Well, next we're going to be talking about the respiratory system, and we're going to talk first about fracture of the nose. The other slides that are in here are about assessment of the respiratory system, so if there's anything that you need to go over and just review, that would be a good idea as well. Fracture of the nose, it starts in chapter 31 in IGGI and on page 581 if you have the new book. Remember that nasal fractures often result from injuries that result from falls, sporting activities, car crashes, or any kind of physical assaults. If the bone or the cartilage isn't displaced, serious complications usually don't result. Displacement, though, of either the bone or the cartilage can cause airway obstruction or cosmetic deformity, and it is always a potential source of infection. So on assessment, we want to document any nasal problem, including deviation, any malaligned nasal bridge, a change in nasal breathing, crackling of the skin, especially what they call crepitus of the skin, and that's when air gets underneath the subcutaneous tissue and you can actually feel the and there come the boys. Hold on just a second, let me pause. Okay, sorry, they just came home from Lowe's. A change in nasal breathing, crackling of the skin, that crepitus I was talking about. On palpation, they have maybe some bruising and pain. They may have blood or cerebrospinal fluid, which rarely drains from one or both of those nares as a result of a simple fracture, but if it's present, it's definitely a more serious injury. You can tell if it's CSF fluid because CSF fluid contains sugar or glucose that will test positive with a dipstick. And when the CSF fluid dries on a piece of filter paper, a yellow halo will appear as a ring at the dried edge of the fluid. Sometimes they'll do x-rays, and sometimes those x-rays are helpful and sometimes they're not. Usually the healthcare provider will perform a simple closed reduction, which is just manipulation of the bones by palpation of the nasal fracture, either using a local or general anesthesia within the first 24 hours of injury. If it's after that, it's more difficult to reduce, and then they have to wait for the swelling to go down. The two interventions that they use is rhinoplasty and nasoseptoplasty. We'll go over some of the nursing care, which is important with your fracture of the nose. Remember, rhinoplasty is just a surgical reconstruction of the nose. It can also be performed as a common plastic surgery. Usually the patient will return from surgery with packing in both nostrils, and this basically will prevent bleeding and help support for the reconstructive nose. The gauze packing is left in. It's usually with an antibiotic to decrease the risk for infection. So we'll have a mustache dressing, usually placed underneath the nose to 2 by 2. And you usually have to count those drip pads, and exactly what's on those drip pads are important. After surgery, we want to observe for any edema, and we want to observe for bleeding. Check vital signs at least every 4 hours when the patient gets back up to the floor. And usually if it's uncomplicated rhinoplasty, they're discharged the day of surgery. Make sure that you keep that patient in a semi-Fowler's position and to move very slowly. Teach him or her to rest. Use cool compresses on the nose, the eyes, and the face to help to reduce swelling and bruising. If they had used a general anesthetic, then we want to have the patient eat soft foods once he or she is alert. Urge the patient to drink at least 2,500 milliliters per day. I think when we talk about the respiratory system, I don't think we can talk more about giving fluids, especially for this situation with fracture of the nose, but also with our pneumonias, with our sinusitis. They think they've drank enough, drink some more. That's how much they need to drink. To prevent bleeding, we want to teach the patient to limit the Valsalva maneuver, such as that forceful cough or straining during bowel movement, not to sniff upward or blow the nose, and not to sneeze with the mouth closed, especially for the first few days after the packing is removed. We may have to order laxatives or stool softeners, instruct the patient to avoid aspirin, other NSAIDs to prevent any kind of bleeding. Antibiotics may be also prescribed to prevent infection. Humidifier to prevent drying of the mucosa is important, and explain that edema and bruising can last for weeks, and the surgical correction may take up to 6 to 12 months. The nasoseptoplasty is just a different term because we're basically straightening a deviated septum, and most of the nursing care is the same as for a rhinoplasty. We'll pause here and then we'll go on to epistaxis. Now we're going to be talking about epistaxis. Epistaxis, as you know, is a nosebleed, and it's a very common problem because there's a lot of capillaries within the nose itself. And so nosebleeds can occur because of trauma, hypertension, blood dyscrasias, leukemia, any kind of inflammation, a tumor, decreased humidity, nose blowing, nose picking, especially our little ones, chronic cocaine use, and procedures such as nasogastric suctioning. Men usually are affected more often than women, and older adults tend to bleed most often from the posterior portion of the nose, and that posterior nasal bleeding is an emergency situation because it cannot be easily reached, and the patient may lose a lot of blood very quickly. Usually the patient will report that the bleeding started, maybe after sneezing or blowing the nose. We always document the cut mount, the color of the blood, take the vital signs, ask the patient about the number, duration, and causes of previous bleeding episodes. And in chart 31-1 on page 582, it tells of the emergency care of a patient with an anterior nosebleed, which we're going to talk mostly of today. We're going to maintain standard precautions, position the patient upright, leaning forward to prevent blood from entering the stomach and possible aspiration. Reassure the patient and attempt to keep him or her quiet to reduce anxiety and blood pressure. Apply that direct lateral pressure to the nose for 10 minutes and apply ice or any kind of cool compresses to the nose and the face if possible. If nose packing is necessary, loosely pack both nares with gauze or nasal tampons. To prevent rebleeding from dislodging clots, instruct the patient to not blow the nose for 24 hours after the bleeding stops, and seek any medical assistance if these measures aren't effective in a home situation. I know a long time ago, talk about the positioning of the patient and leaning forward. Almost all lay people will take that head and put it back, but all that blood just goes back into the back of the throat, and the patient swallows it, and then the patient gets an upset stomach, and then all of a sudden we're vomiting up blood. So not a good idea. So if there is your book goes over this special plug that expands that they can use at home or in the emergency department. It's a special nasal plug that contains an agent to promote blood clotting. It's sold by Hemcon. I've never seen one, never have used one, but supposedly the plug expands on contact with blood and the compressed mucosal blood vessels, and it usually can be removed within an hour. Of course, medical attention is needed if the nosebleed does not respond to the interventions in the chart on page 582, and in those cases, the capillaries may be cauterized with silver nitrate or the nose packed. Remember I said posterior nasal bleeding is an emergency because it can't easily be reached, and the patient can lose a lot of blood very quickly, and the patient is probably swallowing a lot of that blood, so you don't really know how much blood loss there is. So what they'll do is what they call a posterior packing using an epistaxis catheters. They're like nasal pressure tubes. I think, let me see, there's a they can use like a Foley catheter, or a specific posterior packing balloon may be used. But with both of those methods, the tubing is introduced through the nose, similar to the passage of an NG tube, and once it reaches the posterior oral pharynx, the balloon is inflated, and the tubing is pulled back outward to kind of tamponade and put pressure on the posterior bleeding source. And then they use traction on the posterior part of the nose. It's kind of like when you have a bleed, you want to put pressure, and that's the only way that we can really put pressure is on the back, is maybe having some traction on that part of the tube. So after it's anchored into both of them, and most of the time it's anchored, we have tubes in both nares, and that the attached string goes through the nose and is taped to the patient's cheek to prevent any kind of back movement and to help with traction of those catheters. So we need to observe this patient for respiratory distress, for tolerance of the packing or the tubes. Humidity is important, oxygen, bed rest, antibiotics may be prescribed, opiate drugs may be prescribed for pain, and oral care, super, super important. Hydration, very important because of mouth breathing. And we always want to make sure that we do O2 sats for hypoxia. And usually the tubes or the packing is removed about 1 to 3 days afterwards. After the tubes or the packing's removed, you can have the patient use maybe some petroleum jelly, can be applied to the nares for lubrication and for comfort. Nasal saline sprays may be ordered. Humidification will add moisture and prevent rebleeding. And it's important to instruct the patient not to avoid any vigorous nose blowing, or the use of aspirin or any other types of NSAIDs. And strenuous activities such as heavy lifting is discouraged for at least a month.